Hi, everybody. I'm Holly Hutchison, and I'm Dr. Hutchison's sister. I'm regretting to inform you tonight that Dr. Hutchison won't be here. It's just going to be me. I'm really sorry. He had a family obligation, and I really don't get that because I'm his family. And, well, he does have a wife and kids and stuff, but anyway, he is busy with family obligations, so you get the other part of the family, and that's me. So before we get started, all about will it hurt, will it work for IVF, I want to give a shout out to Luce Angelica, who is celebrating her birthday tonight. And so hi to everybody at Caruso's eating dinner right now. I also want to give a little shout out to my favorite little teeny baby, Nicholas, who watches these with his mommy and daddy. And sometimes Dr. Hutchison wakes him up when he coughs. So hey, Nicholas, hope you're watching or actually sleeping tonight. So tonight I'm talking to you from our IVF Retrieval room, which is the place where all the action and magic happens. Behind me is, let's see, you can see we have this very nice anesthesia machine. And we have a table here and all the equipment where we do the egg retrieval. So I thought I would bring that in because sometimes I'll use some of this as props as we talk about, or as people have questions about some of that stuff. Let's see, I've been asked to answer some questions. The first will be about, will it hurt? When I sit down with patients for the first time talking about getting ready to do their IVF cycle, I always ask them, what are you worried about? And what are you afraid of? And the very first thing that they answer is it gonna hurt? Followed by, is it gonna work? So two really valid and important things to consider when you're about to do an IVF cycle. So in answer to, will it hurt? Not really. I think people get really anxious and get really worried about doing shots because they are self-injections, but the needles are super tiny and they're almost the size of a hair. They're really, really fine, and they're about 30 or about a half an inch long. They're really comfortable shots. It's actually like being a diabetic for about 10 days. At the end of the time, you'll know you don't want to be a diabetic, but you'll also know that if you had to be a diabetic, you could survive it and it would be okay. You would get used to it. So I think that that's one of the things that people are the big worry. As far as the egg retrieval hurting, you have the best anesthesia in the world. We've got amazing anesthesiologists that are board certified, and they sit right at your head, are right there through the whole time. It's probably safer to do your egg retrieval than it is to get in the car and have your husband drive you home or your partner drive you home, because you're more likely to get into a car accident than you are to have any pain or problem during the IVF retrieval. After the retrieval, people will experience a little bit of discomfort, but it's like having a bad period. Probably take some ibuprofen and you're going to sail through that just fine. So that's kind of what it's like to do that. If anybody had any questions about all of that stuff, please, send me a little message. I can see that Heidi, hey Heidi, how are you doing? This is really cool. I've never seen this before. So anyway, okay, so the next thing would be, will it work? And will it work will depend on your age, the diagnosis for your infertility, factors of like how healthy you are in general, and also, and today is Mental Health Awareness Day, I think it is. So I'm going to tell you that how your attitude and your mental status and mental health going into it can also affect the treatment as well. So all of those things are really important. Your age, again, as we get older, it's harder for us to conceive and harder for us to carry a child of our own genetic material to term. A lot of older women will use donor eggs and donor sperm. Well, donor eggs for sure. Some will even use donor sperm. So that's another option. Your diagnosis for infertility does play a role in how successful you'll be. People who just have tubal ligation, like who've had tubal ligations or have had their tubes removed for some reason, or their tubes have been blocked, they're going to move through it a lot easier, because the biggest reason for their infertility is just the fact that their tubes are not open. Things like endometriosis will play a factor in whether or not you'll conceive, whether or not your male partner has sperm. All those things come into it. So that becomes more of an individual basis as far as how successful you'll be with IVF. Once we get through the whole process, and I'm going to walk you through that process in a minute. Once we get through the whole process, however, if we get down to having a chromosomally normal embryo, and that's kind of our goal in the IVF process, if we come to that, your chance of conception with a chromosomally normal embryo, pretty much regardless of your age, is about 50%. So if the embryo has been deemed normal, its chance of implanting is pretty good. And if the uterine lining is really good, then you're going to have a better chance of conception with that embryo. So we're giving that at about a 50-50. Excuse me, I've had a cold. You know, there's a lot of factors that go into your chance of conception, and in our office, we'll help kind of guide you through what we think your chances are. Let's see, what else? I've been asked to walk you through the IVF process in general. So in general, you're going to be, the first part of it is to suppress the ovaries. And we typically do that with birth control pills, though not always. Sometimes we're going to do it with other ways. The next phase of it after the suppression, and that, you know, the suppression, we want your ovary to kind of go into a resting position. It also helps us schedule your cycle. After that, we're going to move into stimulation of the ovaries to make more than one egg. And I tell this little story about what the medication does. The medication we use is pure follicle stimulating hormone. In the analogy I like to use is that of an airplane, and little paratroopers are going to jump into the airplane to fly the airplane up to the altitude, and then they're going to jump out of the airplane with their parachutes. So if we think of the ovary as this airplane, the ovary gets loaded in with paratroopers, and each month there's a certain number of paratroopers that are available to be ovulated. In the normal cycle, the plane gets loaded up with the paratroopers, let's say 15, and the plane gets to altitude, and there's only one parachute in the plane. So only one little egg gets the parachute, jumps out of the plane, and hopefully gets picked up by the fallopian tube as it floats down to the ground. What happens to the rest of the paratroopers that were in the plane? They die. They just have been, you know, they don't make it because they didn't get a parachute. When we do IVF, we try to load the plane with parachutes. So that's what follicle stimulating hormone does. It allows your body to not just choose one egg to be ovulated. So we have multiple eggs available for ovulation, which increases the chance of pregnancy. So that's the stimulation process. That's where you do the little shots, and we go through about 10 days of injections before the embryo is, or before the egg is ready to be ovulated. At the end of that 10 days, we typically give you an injection we call the trigger shot, which just means that it's going to trigger that cascade of ovulation. And we do that we time the trigger shot specifically to allow us to take the eggs out before you ovulate. So we usually give you that shot about 32 to 36 hours before the actual procedure of the egg retrieval. Following that, you'll come into the office on the day of egg retrieval. It's all done in our office. Everything's here. I'm sitting in this room. It's a clean room, but it's not a sterile room. So the procedure, nobody's all gowned up. I mean, they will be wearing scrubs and face masks and stuff like that, but it's not super sterile. So you won't have to be draped in a certain way like you might for surgery. It's not that technical. During the procedure, the anesthesiologist will give you an IV in your arm, and that's where they float this lovely drug called propofol, and mixed with a little bit of remifentanil, which is a fast-acting fentanyl product that takes away all pain. And you basically just kind of like drift to sleep like you were on a warm beach on a sunny day, and you're listening to the breezes below, and it's just absolutely lovely. You get really, really relaxed, and you fall asleep, and most people don't even remember anything. Although some will hear things, they will be cognizant enough that you know there's something going on around you, but you're not afraid. You're in a very comfortable, safe place. So it's a very nice procedure. Most patients wake up and go, are we done? Can I go back to my dream? It was really nice. So that's the really good thing. Then you'll wake up, they'll give you some medication to make sure you don't have any more pain after the procedure, take you into a recovery room, get the IV out, watch it for a few minutes, and then let you go home. So most people go home and they're really comfortable the rest of the day. Again, they will have some cramping. If you have any problems, you can always give us a call. We're there for you. It's not like you're just sent home and nothing happens. So following the egg retrieval, we'll know how many eggs you have, how many eggs we were able to retrieve. And the following day, we give you a fertilization report. The fertilization report tells you how many of those eggs actually fertilized. There is typically not 100%. So if we have 10 eggs, we're not going to have 10 that fertilize. A couple of them usually drop off. So we'll usually have like 8. Following that, we're going to watch the embryos develop for the next 5 to 6 days. So we're watching for blastocyst formation. We want those embryos to expand and get where we can see certain structures within the embryo. We're looking for an inner cell mass, which will become the baby. And then we also are looking for the external cells, which are like the parts of the embryo which will implant in the uterus. And those cells form the placenta, the amnion, and the chorion. Those are really important structures to support the pregnancy. So it's from those outer cells that we can actually biopsy a few cells that we send to a reference laboratory to tell us whether or not there's enough DNA or too much DNA in the embryo, and it can tell us if the chromosome complement is correct or not. After that, we're going to freeze the embryos as we wait for the results of that test. Now, some patients won't elect to have, it's called PGTA, pre-implantation genetic testing for aneuploidy. Some patients will elect not to do that, but most patients anymore are electing to do it. PGTA can tell us whether the embryo is chromosomally normal, and it also has the advantage of telling us what the sex of the embryo is. For some people, that's important. They want to know that to plan their families. For other people, it's not important, and they don't want to know what the sex is, which is totally, everybody has their own vision for what they want their family to be like. But it is nice to have that information. So from there, those embryos will be frozen, and typically you go back on birth control pills for a little while we get ready to prepare the uterus for the transfer. Depending on how many chromosomally normal embryos you have, we may be moving into transfer right away because you have plenty of them. You have like 5 or 6 embryos and maybe only want to have 2 children. So at that point, it's okay to go ahead and start with the transfer and see how you do with that. For people who have very few embryos that are chromosomally normal, and as we get older, that's typically the case, there is some testing we can do to make sure that the uterine lining is receptive when we think it should be. That helps pre-qualify the uterine lining for transfer and can improve the pregnancy rate. So there's a lot of information. I'm hoping at one point we'll do just a Hutchison's Huddle on endometrial receptivity because it's becoming very, very important. It was one of the things we didn't really think too much about in the past, and now we're realizing that's a key element to people's success with IVF is whether or not the uterine lining is capable of holding that implanted blastocyst. That's pretty much the process of IVF. It can take like a month for suppression, a month to do the cycle where we make the eggs and make the embryos. And then following that, we have to wait for you to get a period before we can go into the next step, which for some people will be uterine lining receptivity testing. For others, it'll be transfer. So shortest, 3 months. Sometimes it'll take 3-4 months. For some people who we may discover have uterine polyps or some other factor in the uterus that needs to be addressed, it may take 5 or 6 months before we get to the transfer. So it's not a hurry up and it all gets done. It's a long process that can take quite a while. So it's something you just have to work through. That's where your mental health becomes into play. How stressful your life is, how stressed you get during this process can be key indicators for your success or lack of success. We try to encourage people to do what they can to make sure they're getting good rest, have good sleep hygiene, make sure that they're doing things that like exercise or meditation, yoga, having just a few minutes to yourself sometimes is really helpful. Playing music for some people, like for my daughter, her de-stressor is to dance in her room. She loves that. So whatever it is that you can do to help your stress in your life, that's really important as well. The hormones, people always ask me, it's going to make me crazy, right? I'm going to be a crazy woman while I'm doing this. And the truth is you're not. Most people feel pretty good on the fertility drug. The crazy part comes when you're waiting to find out if you're pregnant or not. So it's really not as stressful as you think it might be. Let's see, what other things sorry, looking at my list here. I think we covered pretty much everything. If anybody has questions, please, give me a shout out. Cost-wise for IVF, it's under $10,000 with the PGTA testing, the biopsy of the embryos. That does not include medication. Second cycle is cheaper. Third cycle is even cheaper than that. Or I shouldn't say cheap, it's just less expensive. We discount the cycles once we get from after the first cycle, knowing that some people are going to have to go into a second and third cycle to achieve what they want. We are happy to give you absolute pricing over the phone if you need it. There are some factors if you choose or need to do the endometrial receptivity testing that will cost a little bit more. Some people will have different variations on their insurance coverage. Some people will have some coverage but not others. So all of those things factor into play when you're actually trying to figure out exactly how much it's going to cost you. I know that can be a big stressor of how much it costs, so we're happy to sit down with you. Everybody who's going to be doing IVF sits down and talks with me for an hour, sometimes 2. Sometimes we really get into interesting things like, food culture, and we're in there for 3 hours, and everybody's like thinking I'm having a party in the conference room, which sometimes it kind of is like a party. Anyway, so if you have questions, let me know. We're happy to answer any questions people might have. Just give us a call. Our phone number is 733-0083. We're having our family fiesta this weekend at Reed Park, Ramada 31. I hope people are signed up for that, and we'll look forward to seeing you guys there. And otherwise, we look forward to talking to you. Karina's gonna sign me out, I think, now. Over and out.